Sure. So I have a small case here for discussion. So my disclosures.
Maybe we can ask the panelists to come up because we have a live case that's going to be up next. So maybe you can start to walk up to the panel.
Yeah, so it's a real case. It's the case of an 87-year-old lady. That's a very active lady. Despite her age, she's very functional. She goes to opera. She's enjoying her life very much. She's known for hypertension, hyperlipemia, moderate CKD. She also has non-valvular AF with a CHAD score of 2, CHAD-VAS score of 3, has bled score of 4 with an 8.7% per year risk of bleeding. Her ejection fraction is at 50%. She's referred in cardiology. See, she has never been known for CAD before, but she has very typical and severe anginal symptoms. CCS class 3 out of 4. She's very limited with these symptoms. She also has shortness of breath in YHA class 3, but no other symptom of heart failure. She has no previous bleeding. That's a very frail lady, 59 kilos, less than 5 feet of height. She has mild gait instability, and in fact, she has sustained an accidental fall at home 8 months ago with a forehead injury, but no any further consequence. So given her very typical symptoms, myocardial perfusion scan is ordered, which showed severe anterior ischemia and mild inferior ischemia. So she's referred for the CAT. That shows a very severe, highly calcific 3-vessel disease involving the ostium of the RCA. The distal left main is involved as well. There's also severe disease of the prox and mid-LAD. She has a very high syntax score. Her STS score is of 5%, Euro score 2 of 5% as well. So my first question for the panel is, what would you do next with that lady?
This is a very typical case. Old, frail lady with complex disease, looking at different options that are not perfect at all, whatever you do. Anyone wants to discuss this, what you would do? Sama, you want to start?
I missed that clinical presentation at the beginning.
Stable angina, CCS 3 out of 4.
Okay.
Severe angina, cannot do her daily activities. She has chest pain, sometimes just walking up to the bathroom, sometimes just walking in the house. When she goes outside, she always has angina going to the...
And she has CHADS 2 AFib on apixaban.
It's a complex anatomy, right? It's a very complex anatomy, and if you go working in the left, you don't have RCA support. The RCA is mainly collateralized by the left system. The LAD is not a straightforward PCI. It's tortuous. It's calcified. You have to tackle the left main also. So, of course, she's not a surgical candidate because of her age. Still, you can let her see the surgeon, but I'm not sure in my center, in my reality at least, that the surgeon will jump on the case and take her to the OR. So you
Why
can
not just to limit to LAD and stent that circumference?
If you do it your way, it will be a good option. But if I look to what the surgeons are doing in my center, it won't be in your way, and they will go for a classical sternotomy with a lima on the LAD and venous bypasses elsewhere in this elderly patient, which will be associated with a high risk of complications after the surgery.
So Bob, you would
proceed.
You would not be reluctant to do a mammary to the LAD?
No, I wouldn't be reluctant. I would. How old was the patient? Sorry?
87.
Yes, I mean, she's a frail woman. You have to be very careful, but I think you can do it easily. The thoracotomy approach, I think, is tolerated much better. Is her lung function okay? Is she tolerated an off-pump surgery?
Her LVF?
Is her lung function okay?
All right. Yes. Yeah.
Yeah.
Yep.
Okay. So that's what I would do. I would do a combined approach, protected LAD, and then I would read the right alone. I think the right has been occluded for a long time.
Because if you just put a mammary to the LAD, probably you don't need to do anything else, right?
Perhaps, but if anything else is required, you can potentially stent into the circumflex.
So may I ask? I'm always troubled with these very difficult cases. She's got two huge diagonal. What are you going to do if you just put the mammary to the apical LAD, correct?
The diagonals you're asking about?
Yes.
The diagonals are such an overestimated thing. It's not going to do anything. Every time I've gone after a diagonal, I've basically cursed myself every time. I've done Y grafts, and then what has happened, the competition between the diagonal and then the LAD has gone down, then I have to go back to revise it.
Okay.
So I think it's an overrated vessel, the diagonal, and hence
Sure.
I agree.
So,
even
so
for
you've fallen into my trap.
Even
Because
for
it be-
PCI, it won't be a
because
target
it's-
for me, those diagonals. I mean, I want to keep them maybe open just to prevent post-procedural MI, but
So to be honest, I think if we're thinking about, well, I don't think we were talking about medical therapy because she's already on optimal medical therapy. She's on functional class 3. She wants something done, and it was discussed before. So patient comes in, there's something that needs to be done. Surgery is very attractive because she is nevertheless a fairly high bleeding risk, right? The gestalt is that you'd see this old 87-year-old frail patient. She looks at high bleeding risk just looking at her. That being said, the alternative to surgery, there's then conventional surgery and minimally invasive surgery, and then PCI still would require something fairly complex, right? We all agree to that. Would involve probably left main LED at least. So we need to discuss with the patient what are the options and what can be done. So both of these options were discussed with the patient, and then she made a decision. But before we go there, why don't you tell us a little bit, maybe you can poll the panel and then poll the audience rapidly to see how people would actually deal with this. If you don't have minimally invasive surgery, which I think is the standard across Canada, would you consider this patient for surgery? Open heart surgery with sternotomy and mammary to the LAD and vein grafts.
Any other surgeon in the room? Hugues, Marianne?
No, not a good candidate, right?
So, what we know is that she's 87 and she's active, but do we have an STS score? What's the level of risk?
5%.
Okay, I'm sorry.
Yeah.
The LV function?
Normal.
Yep.
Philippe?
Yeah.
So you put out a couple of options. Is it possible, the option of saying we don't have a good approach to this lady and we have to start thinking about end-of-life care?
So,
Because I know you didn't do this here,
Yeah.
and you're going to show us what you did.
Yeah.
And I hope you have at least a 1-year follow-up after whatever you did.
okay, so
because that's going to be
so this
important.
is clearly not an end-of-life case. Absolutely not. This patient is absolutely completely good, neurologically speaking. She takes public transportation to go to the opera. She wants to keep on living. She's smiling. She has kids. The children are around. She has she's thriving. She is not end of life at all. It's not an option, really. Because she came asking for it. She didn't come pushed. She was asking for something to be done. So not end of life.
The STS score is low, but let's be honest here, she's going to be turned down by everybody. She's frail, it's not included in the STS, and it's probably one of the most powerful predictor of complication post-op.
But she's not turned down. She's not turned down by Dr. Ki, though.
I know, but is special. Is different.
We know
Is
he's
different.
special.
But this is the real
Yeah.
world. This is the people
Even-
we see these
Even
days.
this morning we agreed with left main PCI, so it's different.
I mean,
that's for sure.
probably close to half the people here are from Ontario. Half the people are from Quebec. So we have surgeons in both provinces that do this.
But let's be honest and realistic. If you offer just a revascu to the LED, I think we can do the same thing percutaneously. Okay, we can do that. We can also offer the same result. So does she need complete revas? That's one question. And after that, you can decide. But I think she's, in the end, going to be a good PCI candidate. We can do the same job, less invasively.
Okay. So basically, we can go on a little bit because we have a live case in the wings waiting for presentation. So, of course, the patient decided that she did not want to have open heart surgery because we at least discussed it a little bit with her. She had the husband died during open heart surgery, so she did not want open heart surgery. So we told her that she was at high bleeding risk, but we could probably revascularize her percutaneously. That was a reasonable option, possibly, but the risk would be mostly after the procedure during the treatment with anticoagulants and antiplatelet drugs. So we schedule her for elective angioplasty. We plan to do left main and the mid-LAD lesion only. This was the plan because she had high blood pressure. She needed to be treated with medication and so on. So we wanted to do this first and try to minimize the amount of metal we would leave in the arteries, to try to minimize the thrombotic risk, to have options to manage her. And this is what we decided to do. Now, as is often the case, the angioplasty was more complicated than expected. The patient almost died during the angioplasty because we couldn't do the LAD, the mid-LAD lesion. It was so calcified, angulated, couldn't get down anything. Dissected the LAD shut down. Patient almost died. We salvaged her in the last minute using the laser, and we ended up with a case where the patient survived, which was good, but we thought that this was not the right idea to do PCI. In any case, we eventually survived. The patient eventually survived, and we also did. And we stented, and their final result is kind of pretty good nevertheless. So I will show you the final result maybe. You can go to the end of the procedure, and then we can poll the audience as to what you would do with regards to anticoagulation and DAPT. Right? She has a CHAD score of 2. She's 87 with the highest. This score is probably underestimating her bleeding risk. You have the final angiogram, maybe the one on the right. Yeah.
But Philippe, you're sort of questioning the indication in the face of a complication. I think we should make a clear difference between both. I think the indication of PCI was quite clear. She's elderly. She had a good indication for it, and problem happens, and that and fortunately she was managed, and she got through it. There's a balloon pump. Maybe you can ask yourself if you could have done things differently next time you're faced with a similar patient who has a left main and an occluded right as well. So maybe it's. But I think the indication was clear, and there are maybe she should have get a balloon pump to start, or maybe
she was also at very high complication risk for peripheral disease.
So in the end, it's.
In fact, she has PVD that doesn't allow a balloon pump. So in any case, basically the point is she ended up with lots of stent in the LAD and left main, right? Long stents. This was actually, we finalized this with an IVUS, so we opposed it as best we could because we thought this was appropriate to do that. So even though it was very stable, we nevertheless finalized this with IVUS, checked the position of the stent the best we could. There's a dissection behind the stent in the left main, but that's behind the stent clearly, and the stent goes all the way to the origin of the left main. So long stents, and then what do we do with this patient?
There's a big dye that's missing too.
Yep.
That also gives collaterals, some collaterals to the right.
Yep.
But she has no chest pain at the end.
But you're missing the collaterals to the right, and you're totally right. This diagonal was giving the collaterals to this
but you see the angle between the lesion and this diagonal, it was impossible to get back in there.
Yeah, no, that's...
We tried, yeah.
Clearly, Philippe, this is a complex case. This is not the patient you will want to drop the aspirin soon. She has a high bleeding risk. I know you do LAA closure in Montreal Heart. Is that the kind of patient you would consider for LAA closure to extend the double antiplatelet therapy?
So the answer to this is no, because she's not an active bleeder yet.
Okay. She will?
Yet. So just to maybe, can we poll the audience maybe? Who would give let's say the Pioneer? Pioneer? Don, maybe a couple. Coumadin? Coumadin?
Well, the Pioneer.
And then DAPT alone? Nothing?
I think it's wise to do the first 3 months with DAPT.
Yes, exactly.
87 years old.
Her CHADS is 2. One is age, so probably the other one is hypertension.
Right.
Yeah.
She won't have a stroke at 3 months.
And then
so for practical purposes, I myself wanted some kind of a modified Pioneer which I would prescribe, but my colleague would discharge a patient, discharge her on something else, on DAPT, and she's doing super well 3 months down the road. So I decided to keep going for another 3 months, and then eventually changed to one antiplatelet drug and Rivaroxaban.
And when you say DAPT with ticagrelor?
Pardon me?
The second antiplatelet is?
Is not ticagrelor.
Because we don't know if it provides any protection from stroke in combination with aspirin. Ticagrelor.
Okay, so I think while we continue the discussion, we can go up to the live case because we have one in the wings. So maybe we can have the people in the cath lab in Montreal show us how we do.